The biodistribution profile of PD-1 array and the traditional antibodies was distinct. So traditional PD-1 antibodies has broader distribution and was expected to have function in the tumor size. However, their efficacy was always limited in some late-stage cancer patients, particularly those with resistance to the immunotherapy, because the tumor-infiltrating T cells always become terminal exhausted or just absent, so they are hard to be reactivate. So in contrast, our PD-1 array can precisely target the resistance in the spleen, the largest secondary lymphoid organ in our human body. And in fact, spleen contains 1/3 of immune cells, including both T cells and antigen-presenting cells. And what we found is that if we can precisely target the spleen and the immune cells within there, we can generate strong anti-tumor immunity, and we can activate the T cells as well as the splenic reservoir of suppressive myeloid cells. So thereby, it can trigger strong anti-tumor activities. So actually, this approach might be beneficial for the patients with resistance to the immunotherapy, as I mentioned, because the T cells within the tumors are always not function. So we need to reactivating the new immune responses outside the tumors to have new anti-tumor responses. So and additionally, and this is why PD-1 array can target the patients with immunotherapy resistance and also show good response in the cancer patients. And regarding the safety profile, due to the restricted biodistribution and efficient targeting of immune cells, PD-1 array, the effective dosage of PD-1 array is relatively low, which is just 5 to 10% of traditional antibody dose. So it brings a favorable safety profile. So we didn't observe DLT or TRAE above grade 3, just some mild and transient adverse events, and all the patients were able to go home on the same day of transfusion. So that's all.